Okay, good morning. Thank you so much for the invitation. It's an honor always to be here and be sharing our perspective about technology. I'm going to talk to you about expanding the technology of fluorescence-guided surgery in Latin America. That's a different animal, how we look about it, US, Europe, and Latin America. When we talk about LATAM, we refer to the countries that speak Spanish or Portuguese, and although we share the same language, we are really very different in culture, in resources, and in healthcare system. In Latin America, we have countries where there are areas with access to technology and areas that doesn't have the opportunity, so we have very different ways of that technology and how it behaves in the different countries in Latin America. Before we get into the topic, there are a few concepts that are very important for us to understand, and it's about adoption and implementation. When we talk about adoption of a technology, it refers more to the user and how the users introduce that technology into their daily practice, into their routine. When we talk about implementation, it's more how this innovation or this technology is diffused throughout an organization, is diffused or implemented into our institutions and into our daily practice. So these are very two different concepts. Also, it is important to know why do people accept technology? So why do people rely and use something different that is normally used in the daily practice? This is a puzzle of very different pieces. One of it is the technology itself. Can I observe that technology? Can I try it? That's the first step of how we accept technology. It's also complex to use or not. Is compatible with the equipment that I already have in my institution. It's affordable, a very important piece of implementing a technology in our hospitals, and is sustainable. And something that is sometimes neglected is about the users, about the surgeons, about the administrators, the decision makers, because it has to do with emotions, with behaviors, and with social factors when it becomes the reality to implement a technology in our practice. That's a very interesting theory. It's called the golden circle theory that explains why we do what we do and has to do more with biology and how our brain works and how we get to share our beliefs and our trust to a technology. The brain has two parts, the new part, that the rational thinking, the language, that the neocortex, and the limbic brain that has all the beliefs, the trust, and the decision making. So if we explain a technology from the inside out, from the beliefs of a technology, probably it would be better accepted and integrated into daily practice. So what are the beliefs of fluorescence-guided surgery? What is the inside out? The inside out is more precise surgery, safer surgery, so we have better outcomes for our patients. So we share these beliefs with fluorescence-guided surgery. It would be probably more easily incorporated into our practice. Now that we have all these basic concepts, let's see how Latin America is doing regarding fluorescence-guided surgery. If we take into account this market analysis about the acquisition of fluorescence-guided surgery system, we can see Latin America is very far behind from North America, from Europe, and from Asia in the acquisition of equipment. Another way of knowing how LATAM is doing in fluorescence-guided surgery is take the analysis of the website, and we can see we only have Argentina. I think there is something regarding Fernando being an Argentinian, and also Mexico. So from the 10 first countries of active users of ISFGF website, we only have 2 countries of Latin America. That's something to look at. We did a survey in LATAM. We have 35 responses from 12 countries. We did it through FELAC that groups a lot, 18 countries in Latin America, and also key leaders in some other countries. And we have 81% answer that they have fluorescence-guided surgery, mostly in private hospital settings, and 18% doesn't have access to technology. Regarding the applications, the most frequent one, and I think it's worldwide, cholangiography was the most frequent, followed by perfusion in colon surgery, gastric or esophageal surgery, ureter identification, and sentinel nodes. So this is very interesting to know how LATAM is using technology. Not to show something that is new, that innovation model that probably by now we know by heart. The one thing that I want to point out is probably LATAM will fall into late majority or laggards, not because surgeons in Latin America are not interested or bold enough to try a new technology, but because when technology is going down from the tipping point and it starts going down, also the price of the technology is going to drop a little bit and probably will be more accessible for countries in Latin America to buy equipment for fluorescence-guided surgery. Which ones are the barriers that we can find so we can target those barriers and overcome them? The first one would be the specific characteristics of that technology. With fluorescence-guided surgery, probably that would not be a barrier. It's a very straightforward, intuitive equipment to use. There are some barriers regarding the technical aspect of dosing and timing. The effect on the protocols that are established, for example, it's going to affect the time in the program of ambulatory cholecystectomy. That would be considered a barrier at some point. The clinical evidence that we have to support technology use, we have plenty of clinical evidence of the benefits of fluorescence-guided surgery. Regulatory affairs in Latin America, it's a very important one because we have ministries of health, lots of bureaucracy and paperwork, so we can have countries in Latin America 2-3 years before the acceptance of ICG to be used in the country. Also, the characteristic of the decision makers. Usually we have problems with administrations of the hospital, letting us to buy equipment and to buy equipment that is a little bit higher in price than the normal laparoscopic equipment. And also if the technology will have a reimbursement or not when it's used, paid by the security insurance companies. Going back to the survey, we have 33 responses, and these are the 5 causes of barriers in Latin America. Lack of training, the cost of the near-infrared systems, the equipment accessibility, the cost of ICG that probably is usually around $300 to $350 in Latin American countries, and one that appears to me very interesting is that surgeons didn't find any advantage of using technology. So how do we overcome these barriers? That would be providing training to the surgeons. Probably that will take down the first and main cause of not using technology in Latin America, having access to literature and to clinical evidence. Also working into the established protocols to incorporate the use of ICG, for example, designing a protocol for the application of the dose of ICG before a cholecystectomy in a program of ambulatory cholecystectomy, and also having resources to can address the challenges after the incorporation and implementation of technology. That would be having guidelines to for example, the nurses or the staff to have troubleshooting for the equipment, troubles that we can find in the OR, etc. What are the strategies regarding the equipment that could be applied in Latin America to be able to have fluorescence-guided surgery systems in our hospitals? The first one would be engage the stakeholders very early in the process, not only the surgeons that probably that be the ones pushing to have the equipment, but the administrators, and also educating the patients, because the patients requesting surgery with fluorescence-guided equipment, that is somehow a way that we can do pressure to our administration to have equipment. Also, the cost-effective analysis that was already discussed for the previous presenter, that if we can show that we can have less burden because of leaks of colorectal surgery, that there we have savings, or in sentinel node that we can have not using technetium-99, and we have just a procedure in the OR using ICG. That's a cost-effective analysis that could take some of the burden of the economics in our institution. Also, when the time comes to update laparoscopic equipment, take advantage of that moment to ask and demand to take in laparoscopic equipment that includes already in the system near-infrared systems. And also, the technology providers should participate in the training of the surgeons and the staff. What are the resources that we have to overcome the limitations about knowledge and about training? We have access to publications, we have a dose chart, and we also have a browse with specialties that we can consult when we are doing specific procedures. For education, we have the opportunity to participate in LATAM webinars, also to participate in meetings like this, to have an approach to other LATAM countries and participate in meetings in LATAM, for example, in FELAC in Guatemala that groups many other surgical societies, and also work directly with specific societies in different countries that will have different needs depending on the country. Mentoring in the OR, it's an excellent way to take out the gap of training in the surgeons. Here, the technology providers usually play an important role, not only friendship and having the opportunity to have your friends or experts in your country, but also technology providers working to get together surgeons and experts to overcome the difficulties of implementation of new technology. There we have Fernando and Raul in Costa Rica, and also Fernando and Dr. Sinagra working in Argentina and doing mentoring in their country. Another alternative that it has to do more with a little bit of technology access would be telementoring. Telementoring would be very impacted by the experience of the surgeon, of the mentee, and how the instructions are interpreted, but is an excellent tool to eliminate the distant barrier, and we can have verbal guidance, or we can have guidance with telestration, and also WhatsApp and an exchange of information with the mentors will work. Social media is an excellent way of improvement and development. We can exchange information between peers in social media, and it's a way of taking awareness of technology around the world. So what are the key takeaways for a seamless integration of technology in our hospitals and in our practice? That would be, like everything, a multidisciplinary approach, lots of communication, providing training to the surgeons and education, involvement of the stakeholders very early in the process, not only surgeons, but administrators and patients, and never losing that our goal is to have better outcomes from our patients when we want to implement or adopt a new technology in our practice. So this is it. Thank you so much.